So Paul, let's start off with the most basic of questions. Who are you and what do you do?
Fair enough. I better know the answer to that one. Paul Wilder. I work at Commonwell, the executive director or CEO, whatever the equivalent for a nonprofit.
Yep.
And Commonwell is a large membership organization, a trade association, technically a 501c6, made up of mostly electronic health record vendors and other HIT, health information technology stuff. And we make interop work.
Excellent. How is interoperability working today for you guys? Where do we see some of those bright lights or those bright spots that should give us like encouragement that we're moving in the right direction?
Well, the most encouraging thing comes often from disasters, right? So something goes wrong, and then you realize what you're missing something.
100%.
So we also had the Change incident and cyber attack, and you probably don't even know this before we sat down, but we were part of that.
Oh, okay.
So the Commonweal infrastructure was on that, and the amount of calls we got asking for how quickly it's going to come back tells you that people care about this stuff now.
They do,
right?
They do.
So, if I went back 10 years ago when we had, say, 10 sites on the first year, they weren't geographically near each other. There wasn't much exchange going on. Those were just the early willing that were just, let's see what happens.
Yeah.
But now it's a critical part of the infrastructure of what happens in healthcare. So, from disaster, you learn how important you are.
Oh, 100% true. What is it like being at the head of an organization like this that is really focused on kind of like a singular mission? It's just interop, which obviously is vitally important because people move, information needs to move with them.
Well, the interesting part is we're actually only a piece of interop, but a pretty darn big piece, right?
Yes.
So what we do is we have a record locator, a central repository of where the data is. We don't hold the data itself. The clinical data is distributed throughout all the endpoints. But we make it much more efficient to go find it all, right? Because we're getting registration information every day, every second, every millisecond. Paul's here, Paul's there, Paul's there. When you ask, get me all of Paul's stuff, we know where to go get it. So it's the scale is huge. It's a couple billion documents a year, a couple 100 million a month. Yesterday it was 0, but we're actually expecting to go back up either later today or tomorrow. So we're there.
Wild, absolutely wild. What's it like from the user experience? Do they even know that Commonweal is making this stuff happen in the background?
It's funny. I thought no, but I've discovered yes. Because I assumed that our members would package it as like an interop service package, and like Commonweal isn't a name they even need to know. It's like you need to know the FTC if you're not a telephone company. It's like it's not that important. But it turns out they do, because a lot of the members, their customers were calling us. So it was individual hospital facilities, the VA, like, okay, when are you going to be back up? We want to get it updated. It's like, well, actually, you really kind of got to get it from your member, because the way they incorporate our stuff could be a little different. So me saying up or down, or what backup path to use, I don't know what they are. Yeah. So so we would broker a lot of conversations with our direct members of what to do.
What's that like managing a network? From the sounds of it, it sounds a little stressful to me, knowing that you are the linchpin, and something goes wrong there, suddenly that information that was available isn't, and we know the downstream effect of that.
Yeah. So this woman who works for me, Liz Buckle, Director of Product, a fantastic egg, knows her stuff. I see her all the time, I talk to her all the time, I go, this is fun. She's like, this is not fun. I was like, well, you see how important things are, you see things you need to fix, and you move forward, right? So, a lot of things are changing now in terms of people, how they deal with security and the like, but the importance of the system is there, we know that. So that's actually good feedback. It's hard to get that. When things, you don't generally call a customer service department to say they're doing a great job.
100%.
Like how many times you're calling an airline up and say, this was just the best flight I've ever had. Thank you, right?
Never.
Actually, I did once. I had a flight attendant went out of the way. I forget why. I said, you probably never get this letter, but I'm on this plane, and you just have to know that Joan did a great job, blah, 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 blah. I was like, the movie sucks, I might as well send a letter.
That's fantastic. What are some of the challenges? Interoperability is one of those moving goalposts. You get to a certain threshold, and it's like, okay, now we have a next target. Where are the obstacles? Where are the challenges that you guys see in the industry, in the healthcare system?
So first of all, we're surprisingly not done with hooking up the things that they need to be hooked up, right? So we're top heavy at first. It was the biggest EHRs that came here, and we had built interop services. We still have a lot of specialty in smaller size EHRs that don't know what to do. So take like something that just does asthma control or ENT services or OBGYN. It's a $40 million a year product, probably built by a couple clinicians for themselves, and then they made a business out of it on the side, right? They're not really here yet, and they don't know when to enter. We just go out there saying, it's time, it's now.
Yep.
The exchange is large enough that you're not an early adopter that's going to be tortured by this. there's a lot of data. But you have to share your data too, and they don't always know that.
Yeah.
That it's really a potluck. You have to, you get your plate, you pay for the plate, but you also bring an appetizer and entree, and you got to share with everyone else, and they share with you. It's kind of like a data potluck, and so they don't always get that. But the real opportunity is coming in new use cases. Patient access is growing, getting the payers involved, and then completely different types of things. So labs, pharmacies that you don't think of traditional data holders or IT systems, but they are. They have a lot of data.
It's interesting because I know we talk about equity in healthcare, mostly it's like health equity, but then I also think about, to your point, like the parts of the care continuum that just haven't really benefited from the massive adoption and investment in tech. And I think about, we got this aging Medicare population. There's going to be a lot of skilled nursing facilities, assisted living communities that I imagine would benefit from this type of information. I get how much.
Let me give you a number, just so you just something to anchor on here. There's a study done. I think it's done by the CDC, which is a strange one to do this study. They do a physician study every couple of years. According to that, there's about 210,000, between 200 and 220,000 clinical sites in the country. Right, that's a lot of sites.
That's a lot.
If you look up on my website and then on Care Quality and the others that kind of do this stuff at scale, we'll talk about between 30 and 50,000.
Okay.
So think about that, right? We've only hooked up a quarter of the sites. Now, what we have done is we hooked up the big ones, so we probably have about 80% of the data, but the 20% missing could be really important. And in an equity sense, like it is likely the smaller EHRs or things that are in rural whatever, we got to get them hooked up because the data exchange actually democratizes. It actually makes it better for you to run to your license, right? Because now you may be a small provider in North Dakota, sitting there by yourself, and all your patients go to hospitals that are far away. They're all connected, right? So you need to get connected to be able to do better. Now, it's going to hurt at first because you're going to get all this data and not know what to do with it at first because more data isn't always the best thing.
Growing pains
and new workflows. But we do have a lot more to hook up. Right? We've really done about 25% of the units. They just happen to be really big units.
Gotcha. Now, in terms of kind of steps forward, you talk about use cases. You need those use cases. It's healthcare. You have to have the evidence to back up the claims you're making, not the administrative claims. But I'm curious. But I'm curious about kind of where are you guys setting yourself? Like, what's on the horizon? What are some new ideas that are coming, like that are emerging as a result of working on this day-to-day stuff?
Yeah, what's interesting. So you'll see FHIR, FHIR, all that stuff. That has been around for a long time and gone nowhere. It's been embedded into some regulatory processes with ONC, and that's fine. But the reality is most entities, most technology companies built the server-side capability, the ability to respond to a FHIR request, because that's what the policy said you had to do. They didn't build the part where you ask the questions, the client side. And I think right now we are seeing some new use cases that would not work well in a document-based exchange. And labs is a great example, right? It's a very discrete data element. And what I say often is it's like you're trying to get a mortgage and they ask you for your income and your debt, and to answer your income statement, you send them your entire tax return. Right? When all they needed was line 1, right?
I remember.
This is how much I make, and this is how much my wife makes. Here's my household income. Instead, like today, we send around big documents, and they just want what's on page 72, line 3. And FHIR allows you to kind of pinpoint that stuff. The bad news about that is it's a lot more transactions because it's these little discrete elements happening all the time. And most of them are direct database calls as opposed to documents are created, stored, and then reused over and over again. So we are a little concerned about the volume impact of that, but it's moving now. And labs is a great use case to say, get a major lab on and watch how much FHIR starts to get used.
So is it like just being more efficient and like just making that straight connection versus I'm going to send you this massive payload. To your point, because I imagine you don't want to strain the system more than you need to.
Correct. It's also, from a security perspective, it's better. Less hops, the better, right? So if Commonwell is a gateway. So you ask for a document from us, we know where to get it, we collect it and hand it to you. We don't store that in transit, it's encrypted, that's good security itself. But, if the two FHIR endpoints can just make that conversation themselves and take out a middleman, that's even better. Now you're in control of your own edge, right? You rise to whatever security level you want, whatever TLS3, whatever it is you want to do, and have that conversation. So we would just become the traffic suggester in that mode.
100%.
Right? So you come to us and say, where is Paul's data? Here are the 5 FHIR endpoints we know of that have the data. Go have that conversation yourself, get just the data you need, and exit. So we start thinking of payers, public health.
Yeah.
Great example, public health. Technically, they have a waiver under HIPAA to get data from clinicians, and that's fine. you're supposed to give the minimal necessary that they need.
Yep.
And the reality is, today, to use our existing machinery, we have to send them everything, because that's all it knows to do. So you change it from treatment to health, you're still getting the whole document. They don't want it, and then the other side doesn't want to give it either. But at fire, they can say, I'm looking for immunization, I'm looking for this, I'm looking at this, I just need these 7 elements. That's my minimal necessary for the whatever registry or whatever I'm doing. Great, move on.
Last question for you. Conference like this, what's in it for you? What are you trying to do while you're at a conference like this? You're trying to reach out to more partners? You're trying to build deeper relationship with your current partners? What's that like?
Of course, the answer is both. But I will say this is probably more about finding the next thing to do. Our existing members, we communicate with them regularly, right? Yeah. So we have an annual summit that's just our membership that we do in the fall. So we're here more to get to the next guy. It becomes a great place to have all those kind of sales and BD meetings. I don't know if we don't really call it sales. There's a check that gets hit by someone.
Yeah,
so no mission without margin. You still have to have some money to do this stuff. But it is to get out there. If you look around now, you'll see that a lot of the intermediary companies seem to have more traffic in their booths than does like an EHR company. Because the providers aren't coming here as much. It's a lot of BD, business to business. Of course, the hospital's a business too.
Yeah.
But the IT business to IT business, because there's so many extra things and layers and multiple ways you have to connect and do interop. So it's been pretty busy.
Awesome. Well, Paul, thank you so much for being with us on Healthcare Strategies. Really appreciate it.
Thank you.
Enjoy yourself.
You too.